We're going to take a look at the factors affecting pulmonary ventilation. The flow rule applies to airflow just as it does to blood flow. So airflow depends on the pressure gradient and also the resistance. So remember, the pressure gradient that drives airflow in and out of the lungs is the difference between the atmospheric pressure outside the body and the intraalveolar pressure inside the lungs. So if the pressure gradient is higher, that will increase the airflow. So for example, if you squeeze your abdominal muscles and you force more air out as you exhale, you will increase the airflow. And then resistance also affects airflow, but there's an inverse relationship. So if you increase the resistance, you would decrease the flow. So for example, if you bronchoconstrict, that would decrease the airflow. So let's take a look at resistance. It's affected by two different things. We have lung compliance and airway resistance. Remember, lung compliance is just how easy it is to stretch the lungs, and that's affected by the elasticity of the lungs and the surface tension. So let's take a look at lung compliance first. The lungs have a high compliance, which means they're very easy to stretch. So it's really easy to inhale and expand the lungs, so you don't have to work very hard to breathe. There's two factors that affect the lung compliance: elasticity and the surface tension of the alveoli. The lungs are very elastic, very easy to stretch, but if scar tissue forms in the lungs become stiffer and have a lower compliance, and it's harder to expand them. So you have to work harder to breathe in. So where we would see diseases that increase scar tissue in the lungs would be, for example, tuberculosis and black lung disease that we see in coal miners. And if you're interested in seeing how the elasticity of the lungs is affected by scar tissue, there's a good show here on black lung disease in coal miners if you want to watch that. The other thing that affects lung compliance is surface tension in the alveoli. So there's a thin layer of water on the inner surface of the alveoli. And water likes to form hydrogen bonds with other water molecules, and so it likes to curl up into a ball if it can and form water droplets. So if that happens inside the lungs, as the water molecules join together and curl up, they will also pull the alveolar walls in and could collapse them, which would make it very hard to reinflate them because it would be like trying to pull two paper towels apart. So in order to decrease the surface tension of the alveoli and increase their compliance, we're going to secrete surfactant, and that's secreted by type 2 alveolar cells. The surfactant is like a detergent. It's an amphipathic molecule. There's some phospholipids and proteins in it, and they disrupt the hydrogen bonding between the water molecules. So that prevents the water molecules from curling up into a ball and forming droplets and collapsing the alveoli. What happens if there's not enough surfactant? We see this in infant respiratory distress syndrome, which occurs in premature infants that are born before 7 months of gestation. They're not able to produce enough surfactant yet. So what happens to the surface tension in the alveoli? The surface tension will increase, and that will decrease the compliance, which is going to make it harder to expand the lungs. And so that makes the infant have to work a lot harder to inhale because the alveoli will collapse as they exhale, and then they have to work really hard, create a really high pressure gradient to reinflate those collapsed alveoli. So to treat these premature infants, they are oftentimes put onto a ventilator, and the machine will do the work of breathing for them. And they can also put synthetic surfactant down into their lungs until they're able to produce it on their own. Airway resistance will also affect airflow. So as the airways get smaller and smaller as you go down towards the bronchioles, you would think that their total resistance would increase. But because there's so many bronchioles and their total cross-sectional area is very large, the overall resistance of the bronchioles is actually low. And that's good because you don't need a very high pressure gradient in order to get the air to move in and out of the lungs. So that makes it easy to breathe. But if you increase the resistance, that'll decrease the flow and make it harder to breathe, and you're going to need to generate a much higher pressure gradient to get the same airflow in. So on these graphs, the first line here is showing you normal airway resistance. And so our intraalveolar pressure just varies from -1 in inhalation to +1 during exhalation. But if you increase the resistance, maybe the person is having an asthma attack and the airways have really narrowed down. In order to get the same amount of air in and out of the lungs, you have to really increase your pressure gradient. So you're really going to have to work a lot harder to breathe in and out to get the same amount of air in and out of the lungs. So let's take a look at factors that affect airway resistance. We can change the airway diameter by either contracting or relaxing the smooth muscle around the bronchioles, or by increasing the mucus secretion in the airways. So with bronchoconstriction, that would increase the resistance and decrease airflow. Whereas with bronchodilation, that would decrease the resistance and increase the airflow. And if you increase the mucus secretion in the bronchioles, that would increase the resistance and decrease the airflow. So the smooth muscle around the bronchiole, the contraction and relaxation is controlled by three things. The autonomic nervous system, remember that sympathetic stimulation will cause the bronchioles to dilate, and then parasympathetic stimulation causes bronchoconstriction. And then hormones, epinephrine from the adrenal medulla, which releases that with sympathetic stimulation, will cause bronchodilation. And then some local chemicals that are released in the area of the bronchial smooth muscle can also affect contraction and relaxation. Histamine, which is released from some of the white blood cells, will cause bronchoconstriction. And then carbon dioxide. High levels of carbon dioxide will cause bronchodilation, and low levels of carbon dioxide will cause bronchoconstriction. And we'll look at that in Chapter 17. There are a few diseases that increase airway resistance. We have asthma, which is acute or temporary. So you're going to increase your airway resistance during an asthma attack, but then the rest of the time you'll be normal. And during an asthma attack, the bronchial smooth muscle constricts, you increase the mucus production, and the bronchial walls become inflamed. And so all of that will increase airway resistance and make it harder to breathe. And then chronic obstructive pulmonary diseases, or COPD, includes two things: chronic bronchitis and emphysema. So both of these are going to be chronic. They're always going to be present. And these are caused by smoking and air pollution. And usually people will have a combination of both of these at the same time. Here's what happens in asthma. So most of the time the airways are going to be normal, but during an asthma attack, you can see that the smooth muscle has constricted, the walls have become swollen, and there's also a lot of mucus being produced. So that really increases the resistance and decreases airflow. So the person's going to have to work a lot harder to breathe, and they'll be wheezing and gasping for air. This video link here shows an actual patient during a severe asthma attack if you want to watch that at home. COPD includes chronic bronchitis and emphysema, and both of these are chronic, and they're both going to also increase airway resistance. So in bronchitis, we get inflammation of the bronchi and bronchioles. The walls get swollen and increase mucus production that will increase resistance, decrease airflow, make it more difficult to breathe. And in emphysema, the problem is down in the air sacs. So the normal alveoli is pictured on the bottom, and then the alveoli with emphysema, they're pictured here on the top. So with the chronic inflammation, the walls of the alveoli get destroyed, and that's going to cause two problems. One is that you're going to have less surface area for gas exchange, and then the other problem is that it's going to increase the resistance, because as you go to exhale, with those alveolar walls gone, those air sacs will collapse part way, and it makes it difficult to exhale as much air as you should. And so that'll increase the resistance and make it harder to breathe.